Hi everyone, my name is Somaya Sadat. I'm the Assistant Director at the Center for Analytics and AI Engineering at U of T. It's my pleasure to welcome you all today to our first seminar of the year titled Data and Decision Sciences to Support Planning in Ontario Healthcare System. We are hosting Dr. Saba Wahid from Ontario Health today. And my co-panelists are Professor Mike Carter from Mechanical Industrial Engineering and the Center for Healthcare Engineering, who is co-hosting the seminar with us, and Alex Olson, our research associate at the Center for Analytics and AI Engineering. While we're waiting for the rest of the people to join us, let me just give you all a quick introduction to both CART and the Center for Healthcare Engineering, and then we can start the seminar. So I'm going to share my screen. CART, or the Center for Analytics and AI Engineering, was founded in 2019 as the hub for collaborations in AI and analytics at U of T's Engineering School. We have 91 faculty affiliates from across the departments within the Faculty of Engineering. Our director is Professor Tim Chan from the Mechanical Industrial Engineering, and we are guided by a steering committee from representatives from across the faculty. I'm the assistant director, and Alex Olson is our in-house AI/ML expert. We run a number of activities under three pillars of research, education, and partnership. Under research, we fund high-impact multidisciplinary research. We connect faculty with analytics and AI projects with the students. So if you're a U of T student looking for analytics and AI and all projects, feel free to forward me your CV. We run research drop-in clinics. These are clinics you can sign up for, and the link to those are on our website. And Alex will spend time with you and provide some guidance on techniques and tools. Under education, we just launched what we call Pathway of Courses across the University of Toronto. So this is an intelligent search engine where it really helps you to find more interdisciplinary type of courses. And it also proposes a sequence of prerequisites to prepare for more advanced courses. This was also launched pretty recently, and you can find a link to that on our website. We have released an information repository on cloud computing resources, and that you can also find on our website. And the newest addition to our website, on a bi-weekly basis, we will be posting experiential learning opportunities with the Mitacs Accelerate internship program. And on the partnership side, we have our industry speaker series, including today's one. We conduct applied research projects with leverage funds from government sources with our partners. We provide analytics, AI, and ML consulting to our partners. We provide executive and technical training to our partners, and we support our partners to recruit talent from U of T. For more information, make sure you visit our website, subscribe to our email list, and just follow us on social media. And the Center for Healthcare Engineering, CHE, has a dedicated list of faculty who conduct research in operations research, information engineering, and human factors applied to healthcare settings, and you can see their names here. There are three levels of research conducted at the center. At the policy level for the system, they try to propose guidelines in public health and also work on modeling and forecasting needs. At the macro level for the providers, they work on resource allocation, utilization, and throughput, as well as provider operations. And at the micro level, it's more around research on patient-centered decision-making, technology, and diagnosis. And the website is che.utoronto.ca, and this is the contact information. Feel free to reach out for more information. With this quick introduction, we're going to go into our seminar today. The way this seminar works is that it's really a conversation between the panelists and our speaker, who is Dr. Saba Wahid. Dr. Saba Wahid leads the Advanced Analytics team at Ontario Health Cancer Care Ontario. In that role, she oversees the development and implementation of analytics tools Dr. Wahid holds a PhD in operations research from the University of British Columbia. Her areas of expertise include optimization and simulation modeling utilized to address planning and prediction questions in Ontario's healthcare system. Throughout the seminar, if you have any questions, feel free to just type it in the Q&A box. Me and the rest of the panelists will just read those questions to Dr. Wahid, and we would also carry on the conversation with her. So thank you, Dr. Wahid, for joining us. I'm going to start with a very quick question. Can you briefly introduce yourself? What's your background? What is your current position? And what other relevant positions have you held in the past?
Sure, thank you. Thanks for having me. Hi, everyone. Thanks for attending this. I see many participants. So I'm Saba Wahid. As Sumaya just said, my background is in industrial engineering, and I have my kind of graduate degrees were in operations research. And I actually kind of started, it's interesting because my kind of background when I was doing my grad school was actually in forestry. So I got both my master's and PhD kind of working with natural resource management and using simulation optimization in that context. Then I did a postdoc at Université Laval, and kind of while doing that, I had the opportunity to actually apply and join the kind of Cancer Care Ontario agency at the time, now part of Ontario Health, as a methodologist in a kind of a newly born advanced analytics team that Sumaya knows too well about. She was actually a founding member of the team. So I joined as a methodologist, and basically that team was really founded with the objective of supporting the efforts of the agency in their kind of planning for providing various health services in the province, and kind of advise the ministry, and really started as an OR shop. So it was more for, kind of using OR techniques in a way that allows, allocation of scarce resources, as those in the operations research community are well familiar with. And then we kind of expanded from there. So it really was an OR shop to begin with, but then as we hired more staff, we kind of, I want to say, like, delved more into, a bit more of statistical modeling, a bit more of kind of data science, let's say, kind of after that. And over the past, it's been now 7+ years that the team was kind of founded. The original founders are now not there. I'm leading the team now. And we went through many changes. So as kind of first being part of Cancer Care Ontario only, and then as kind of the health system in Ontario kind of went under the recent transitions. We're now part of Ontario Health. We are trying to kind of figure out our place now within this new agency and how we can support kind of broader mandate than we did before, where we were mostly focusing on obviously cancer and renal type of services that the agency was delivering. Now there's obviously much more to work with, but it's been interesting. I can't say we found our place yet, especially as the pandemic hit and as in a new agency. It's definitely been a challenge, but yeah, we're looking forward to see what the future brings.
Awesome, thank you.
Yeah.
So to sort of expand on that a little further, could you talk a bit about how decision sciences are currently supporting health system planning? And maybe you could give a few examples where analytic solutions are informing decisions.
Absolutely, would be happy to. So I think it's a bit of, again, like I'm going to refer to some of the kind of projects that were really completed when we were still Cancer Care Ontario, but also there's one recent example when during kind of the pandemic we helped with an aspect of planning, and I think the examples will definitely be kind of expand, or the projects will expand as we learn more about how we can be kind of active in other areas. So really the way we usually kind of supported CCO or Cancer Care Ontario previously was really in two areas. So either kind of operational support, where you had programs that were already in place and services that were already being offered, and we wanted to kind of help, optimize allocation of resources, or really help with predicting the demand in the future and how much more we need to be providing these services, or how different we can provide it, versus completely new models of care. For example, when a new screening test was going to be kind of rolled out in the province, and what the demand for that and for the follow-up services after that would look like. So we had these kind of two streams of work, and I think like we saw, especially with operational planning, we saw a lot of uptake. So I'm going to share, I think, my screen. Second, and I can just do this. So some of these are really historic, but do you see my screen now, the PDF file?
Yes.
Yeah, okay. So yeah, so it's kind of like this example was, as I was saying, kind of like when a new screening test was being rolled out for colorectal cancer screening. And we were kind of trying to figure out, okay, what the demand for services would look like, specifically in this case, colonoscopy that would follow after a positive test. So this was like in essence, it ended up being a very kind of simple model in terms of, you would just look at simple arithmetic of like multiplying things together, but really getting to that point, trying to figure out what is the product or what is the analysis that would actually help the stakeholders make the decision, and what is really that decision that they can make, and what is the lever that they have. This was an interesting project to work on just because of that, because obviously there was already funding in place for these services. Colonoscopy was still, what was happening in the province, but as this more sensitive test was being rolled out, what could be expected, and what, how could we shift resources or shift funding from one type of, let's say colonoscopy bucket to another that would allow kind of efficient use of that resource, and that would also meet this new increased demand for services. So this, I want to say, the interesting part of this project was really the stakeholder engagement, trying to build trust. This was one of the earlier projects that we did in the team. We were not at the time really known or I don't want to say trusted, but like we really had to get buy-in from the stakeholders, and it was tough as one of the initial projects that we did. But in the end, I want to say I was like the final kind of tool that came out of this was really an interactive Excel tool that people played with. And it was in use for a good like 2 to 3 years as the program was being designed and being rolled out. And this was kind of trying to just show how much extra capacity at a regional level was required for colonoscopy, like this graph, that's what it's kind of showing. Would some areas face challenges with their colonoscopy services, and would there need to be kind of additional funding to support that? There was so this was kind of an example of a new program that was designed. In terms of operational support, I'm going to come back to this one. I think one of our kind of, again, a super early model that was developed over multiple iterations, so it's still in use today. And this was literally the first product that our team developed in 2014. This is really looking at planning for dialysis capacity in the province. And it started, I think we had an amazing co-op student at the time that's now gone on to do great and amazing things. And he helped build this model where we were trying to predict the demand for dialysis services and kind of see if different dialysis centers have enough stations to kind of deal with this demand over the next, I think the projection is really going a decade into the future every time we refresh this. And this was something where, you had to do forecasting in like with this tool, and then do this other thing, like, do your kind of multiplication, whatever, like looking at the population in Excel, bring things together in a tool that you can actually send off to the program to be able to use. So I think, again, with this model, over the multiple iterations, we learned to kind of capture all the different assumptions that the program was really interested in. So the renal program within Cancer Care Ontario that was in charge of funding these services, they wanted to see multiple levers that they can play with. They wanted to really kind of see how they could relieve pressures if there was, especially in recent years, if they could by looking at different modalities of or pushing for different modalities of dialysis, especially if patients would take up dialysis at home, like what impact would that have on the demand for in-center dialysis, and which would be obviously more costly for the health system. So this was, again, like this was something foundational. When you look at it, it's not necessarily, I want to say, quote unquote, fancy. Obviously, a lot of kind of rigor went into the back end of this in terms of forecasting the demand. But then when you try to put things together, it kind of looks generally, not super complex. You can explain it to people, but I think that has also been a kind of a cause for uptake of this really well by the Ontario Renal Program. They've been using it every 2 years. We refresh everything in this model. And they use that to kind of assess requests that come for funding, additional dialysis machines in different centers. And it has held up really well. It's been kind of communicated to the regions, to the facilities, and there's really kind of great buy-in for this product. So this has been definitely one of the examples of something that has supported many decisions within the health system. And I think I'm just going to do... And then, yeah, like I think to go to a more like operations research examples, we've built simulation models in a few projects that we've had over the past few years. We've done when the stem cell transplant became an issue in the province, we were asked to kind of build a model that could look at the impact of additional transplant beds on the wait times for patients, because it was, if you remember, it was a kind of a bit of a scandal. Patients were kind of dying on the wait list. There was that problem, and patients were having to be sent outside of Ontario and out of the country for their treatment. So this was a system dynamics model that we built relatively quickly to support the kind of the planning for these additional beds. So this was also something that, again, like definitely made an impact in a kind of a crisis situation, and some of the decisions in terms of funding, like how many beds and over what period of time, was kind of based on the model. I want to say, like when it comes especially to something that high cost and that strategic, there was a lot of also external factors. Like I'm not going to say like the recommendations of this model were not just taken at whatever the output of the model was, but it was definitely a big kind of base of evidence to show how adding these beds would impact at different facilities the wait times for patients. And then we kind of did, again, another multi-iteration model looking at funding of diagnostic imaging services, specifically MRI in Ontario, where we started with the regression. We went to simulation. We, like the most recent one that I just did like a couple of months ago, went back to like simple queuing theory, just divide things by each other with like throughput and like queue length. And so it's interesting because we keep coming back to this because it's definitely an issue in the province. Everyone can kind of relate to. Wait times are long, resources are scarce. What do we do? And we do have a great working relationship with the ministry and with our access to care partners within the agency, who really support the ministry in figuring out the funding recommendations. And we have tried to predict wait times and figure out how to optimize allocation of the funding within regions to really help bring the wait times down. And it's, again, this is not something that feeds directly into the funding recommendations, but this is taken in context with everything else by the ministry. But we've heard over and over that, like, basically to compare different scenarios, they do come back to the model and try to see, the impact of if we, change the capacity from or the funded hours by this much, in certain regions versus, for certain indications, like what will happen to the wait times. So again, like this was something that we did multiple iterations of, and I think it's the uptake has been great, but not necessarily as in we don't have users in the system, but we kind of run, most of the time we run the analysis and we run the scenarios and we present those results to the ministry and to our access to care partners. And then, so this hasn't been really a tool in itself that's being used by external users or by our regional partners. We use it kind of internally and we share the results. But again, like one of those kind of long-standing, I guess, legacy products that we keep maintaining and doing multiple iterations of. And I'm going to come back to the last one. We did have more, but I don't think I will run out of time if I go at this rate. So the last one is the more kind of recent work that like data and decision sciences team was involved, but also it was really a big partnership with our like system infrastructure planning team at CCO or at Ontario Health. We have our access to care partners, cancer programs. It was a huge kind of regional and agency kind of group that came together to really look at the surgical backlog of the basic backlog of surgeries that were deferred because of the pandemic in the first wave. And the work here was really like our part specifically was in the forecasting realm, so trying to forecast the demand for these surgical procedures in the future, and then figuring out, you know, of the people that didn't show up. So I'm going to just show this graphic here. So really looking at the historical pattern and trying to figure out, you know, how many people didn't really show up for the surgery or didn't get their surgeries that should have gotten their surgeries based on their historical demand, and figuring out the difference of those is really kind of the backlog of your procedures that is adding up. And this was, we did this again super quickly. I think we did this like over less than a week. We had to forecast multiple time series for different procedures at the regional level, which meant that some of these, especially highly kind of, I guess, rare conditions or rare surgeries with really low volumes, like trying to figure out what is the methodology that would best or most robustly allow forecasting of these time series. So it was interesting. We fit multiple models to each time series and picked the one that was kind of doing best in terms of error and in terms of kind of looking at our training testing period. And the impact of this one was interesting because when the second wave hit, and it's still obviously raging, like we are seeing that basically because this was published, and I think this was kind of socialized generally heavily among our hospital partners and regions, and they are really using this as a basis to protect time for time-sensitive surgeries as much as possible, as opposed to the first wave, where obviously with a lot of unknowns, many procedures were canceled, where you know, they potentially could have still kind of gone on if you looked at their resource utilization, and they might not need, you know, ICU as much, or, you know, just by looking at the impact of that. So so we are, like, I'm aware of kind of basically using this and similar work that has been done, I think, in other jurisdictions as well, to really advocate for protecting some time, although, you know, COVID is definitely causing issues, protecting some time for some of the more time-sensitive surgeries to still continue as much as possible. So yeah, that's my spiel for this one.
Awesome, thank you. We have a number of questions coming in, but we're gonna keep them all for the very end. I'm gonna pass the floor to Mike Carter to maybe ask the next question.
Okay, can you hear me?
Yes.
Yeah.
Good, okay, super. I'm having microphone trouble. So I've been involved in several projects with SABA, with CCO, but just in general, and partly for me and partly for the audience, can you talk a little bit about the data holdings and what you have access to, and what do I have access to? You know, I don't really care what you have. You've obviously got a wealth of information.
Yeah, no, that's a great question. So, like CCO, the legacy agency, had, I think, 80 plus like data sources. Most of them, I want to say, administrative. So a lot of, because basically the CCO was in the business of like funding the hospitals or for certain services, you know, funding the renal system, keeping track of wait time. So a lot of the data sources that we have at CCO are administrative, so not necessarily super clinical. It's different than what hospitals have access to, where for each patient you would have a lot of kind of clinical information related to their stay at the hospital or their medical history. We have, for example, you know, this discharge abstract database, which is, you know, for every hospital stay, we have, or for every hospital discharge, we have a record for the patient, you know, what interventions were provided, you know, where did they go to the ICU or not, some kind of basic information about the patient. but you don't necessarily get all the detailed information that the EHR have, but it really helps us. Like we've used hospitalization data, ED visit data, physician billing data to kind of proxy a lot of the conditions of the patient. So, by looking at what billing codes the physician uses, you can kind of figure out the diagnosis of the patient potentially with kind of validated algorithms sometimes. We have some process data, so wait times information data that we use for surgical, for kind of diagnostic imaging and for ED visits like that. It really kind of does, it's almost like, it's perfect for basically a simulation modeling because it had timestamps at each step of the way. So, this is when your referral came, and this is when, you were scheduled, and this is where you did show up or didn't show up, and this is how long your procedure took. So it's kind of perfect from that sense. And then we have more clinical data sources that, like pathology data, like lab information data, where you can kind of get a bit more like details into the clinical characteristics. So even within CCO, not everybody would have access to that. There's obviously a lot of kind of privacy legal protection for health information in Ontario and in Canada. So all of that kind of, we really take that seriously, and we use that data kind of even for us to use that data, you need a lot of permissions and kind of training. And from my understanding, all of that data could potentially be released to researchers. We have a very established research data disclosure process that, if you have a researcher takes approval for your research project, and you have like a project proposal that, and you know which data elements from what data sources you need, you can get that from CCO. The caveat is that it does take time. Like you just have to be kind of ready to spend that time, and mostly because it's especially if it's not something that's of high priority for CCO itself, like you're not doing research with someone from the agency, on something that's of high priority at the moment. It's just a resourcing problem because somebody has to extract that data, de-identify that data, check it, whatever, and then share that back. But the process is there. So if you go on CCO's website, or I can maybe share that link afterwards, you can see there's a formalized research data disclosure process. There's also the new Ontario Health Data Platform that is going live. I think a minor part of it has already gone live, but it's basically data that flows through ICES and then through kind of Ontario Health to Queen's University. It's a collaboration between Compute Ontario, Queen's, ICES, Ministry, and Ontario Health, where the identified data is shared with researchers for purpose of COVID-19 related research. And I can again share the website for that. Like you can kind of request access through that website. Because I'm not a researcher, like I, for example, wouldn't necessarily be able to access that because I'm not a researcher, or I don't have a research project necessarily that I can define for that. So I don't know all the details of how you would get access once you kind of go through that. But it's basically a different stream of work, and I think the hope is that in the future, because all the foundation has been built, potentially that can kind of open up to non-COVID research as well. Which, if it does, I think it would be amazing. It's just
I'm just going to add one point here. So what Saba just mentioned, we have some information on the CART website. You can look up crowd resources and data sources available. So what Saba just mentioned, part of it is on the CART website as well. You can check that. And there's one related question to data that I'm going to add, Saba, here, and not wait for the very end, just because it's very related. Do you find that there are data gaps in healthcare? If so, what are specific areas?
Oh my God, yes. It's data. I mean, data, yeah. Well, I think you have, because, I mean, we call this a health system, but I think what we've all learned, at least over the past year, is that it's really a fragmented system. So data exists in different places. So at the provincial level, when I think what we have access, or what even our ministry colleagues or other agencies have access to, is very, as I said, mostly administrative, at high level, where, if you ask a primary care provider, they have access to every detail of your like medical history, and like they would have a lot more, or at hospitals at their EHRs, they would have a lot more detail available to them. So I think the gap is really in connecting these data sources. Obviously, with some things like, again, like you might have heard on the news, like something like race data or like some background like socioeconomics, like some of this data potentially was never collected properly for some populations. So you kind of, I think that gap definitely exists. It's being addressed now, but it will take some years before we can actually, I think, reap the benefits of having more data on that, on those aspects. But even the data that we do have, I think, is in different parts. So it's hard to bring it together for if you want to kind of do a project that needs both the kind of the high level view and that all the kind of the detailed clinical pieces of information. So yeah, that's at least what I think.
Valid point.
Great. So I think to follow up on talking about data sources, I want to ask a bit about methodology. So what types of methodology or methods do you typically use in your analysis? Are you using sort of machine learning methods or other kinds of statistical methods? And maybe also if you want to talk about some of the packages, the software packages that you use. Right.
So as I said, like mostly being an OR person and also being an OR shop historically, we, I can't say we're doing a lot of like I want to say machine learning or AI, the kind of methodology. We're not using a lot of that. We've had brilliant statisticians on the team where, we've done, I don't know, time like Markov modeling. We've done, time to event analysis, arrival analysis, imputation of missing data. So a lot of kind of really foundational statistical work. But for example, because I feel like people just hear like machine learning or like, AI and they're like, natural language processing. But we've never done that. We've never had a use case that actually needed that. But I know there's a lot of interest currently in the agency too, especially with pathology data that we have that's very rich, but it's narrative data, it's kind of text-based. There's a lot of interest in using that. We have not, like in our team, we haven't done that. Currently, we actually lack the skill set. I would love to hire for that, but it's also so in some of those cases we really try to build partnerships. So the agency is really looking to try to partner with other organizations like Vector, like other kind of places where the skill set is there, and there could be these kind of partnerships with that. But what the methods that we mostly use, I want to say, are on the kind of OR side, so simulation optimization. A lot of time series forecasting. I want to say that's where, like, that's literally bread and butter for like everything we do is just forecast the demand first, and then we need to do something with that demand. So, and I think for that we've done not just like obviously the kind of your classic like time series methodology, but also sometimes for some of our projects we fit like neural nets, for example, to try to predict what happens. And for a lot of our forecasting now, instead of picking one method, we usually do multi-method. So we fit multiple models, and then we pick within the same project, we would pick different methods for different kind of components of that time series, depending on what fits better. And that has been kind of pretty generally successful. In terms of packages, a lot of the, like if we're looking again at forecasting or even trying to kind of manipulate data, we use like R and Python for more of the kind of just running again like time series forecasting, or even sometimes trying to, like, we used R sometimes once when we didn't have a simulation software to actually do discrete event simulation, which was interesting. We have a discrete event simulation platform, AnyLogic, that we use, which also allows for optimization within simulation. And we use Excel a lot. Like, honestly, even if we do stuff in simulation, we've had cases where we were heavily involved in the dimensional capacity planning in Ontario a couple of years ago. A lot of work was done in building a system dynamics model and a DES model in AnyLogic. But then all of the outputs of various scenarios were actually exported into an interactive Excel tool that then we shared with the ministry and with the regions to pick their scenarios and then see what the result was. Just because, again, like, just usability. And if you want people to actually look at your stuff and make a decision. You have to make it kind of really easy to digest for them and something that they feel comfortable with. And that's what we found, that like in the end, whatever we do the work in, the results generally get somehow packaged in Excel and shared back. So
interesting. But you talked about a lot about forecasting, and there is a related question on that I'm going to read right now. I think it relates to the slides you shared. So someone asked, Tarini asked actually, what sorts of forecasting methodologies did you use to generate the backlog visual? Did you have a backlog visual in your slides?
Is that, so I'm just going to share this screen again. Maybe. And if you're talking about this, I think this was just a sample time series that we picked. So for this project, we ran multiple techniques, or we fit multiple models to the same time series to pick. And I think they were a range from just seasonal naive to seasonal and trend decomposition methods, with like there was TBAT method. Sorry, don't ask me all the details, because we had an amazing data scientist that did all these models. I can't speak to all the detailed methodology, but I don't know this specific one which method it was. But basically what you're kind of seeing here is the green dot would be the forecast and the blue is the actual, and the difference of the two is what we kind of quantified as backlog. Yeah.
Awesome, thank you. I'm going to pass the floor to Mike for the next question.
Okay, I was just, I tell people I've been doing this for a long time, and I tell people that I spend more time doing change management than I do modeling. And, so I'm sort of curious as to what's your secret about actually getting people to use the things that you develop, and actually getting what are some of the challenges you've had, or tell us some horror stories.
Yes, horror stories.
Yeah,
I mean, this is
about somebody, but
I mean, you've been a part of you've been involved enough that I think you kind of know, I guess, some of the challenges that we're facing. But what we've found kind of over and over is because sometimes obviously like the stakeholders would come to you with a problem and they're busy doing their thing, and they're also not maybe super comfortable with like being involved in more on the analytic side of things. But I think it's really the job of this team, so our team, to keep them engaged and to keep kind of checking that we are collecting the requirements right, or like just iterating and showing like proof of concept or mock tools or whatever, just to make sure that we are capturing it right. Because I think where we have not been successful is when we've done things in silo. Like we kind of just we gather the requirement, we go and we try to like build something, and methodologically amazing, but like it's not what they really needed. And for a lot of our, like when I think about the models that we have been using for years in practice, it's really because we keep coming back to the client. They have questions, they give us feedback, we try to like incorporate it as much as possible. So I feel like that part of like gathering the requirement is really important, and keeping them engaged and keep showing them what we're thinking, like, is this what you need, is this what you need, and then being able to explain things has also been, I think, for us, has been helpful. Again, like we haven't had to necessarily explain, I don't know, like a crazy neural net to anybody yet, so I don't know when that would happen. But with a lot of our models, we've been able to explain, why you're getting from this set of inputs to this set of outputs, and I think that helps a lot, especially when you work with clinicians, when they're like super smart people. They're really engaged, and they want to understand what's happening before they can recommend the course of action. And I think that has been for us really what has worked in our favor. And where, like I think, for example, when I'm thinking of simulation, like it's been tough to try to explain simulation, like why you enter this and then you see that, and it is a bit of a black box, and we have tried really hard to try to be able to explain that in the best way possible to people that are not familiar with the methodology. But like I feel like that's where it falters, and I think that's where we have to, like, for a lot of our simulation tools, we've had to basically absorb the analytical portion of things and then try to just like share the results in a way that people can anyway better understand or interact with more easily. So that has been, I feel like, the main thing. And I think I had yeah, and another like key issue has been when there is not a decision that the result can plug into. So sometimes, like, I feel like when the levers aren't there, you can do whatever you want to do. If the decision maker, just looks at the result and is like, nice, but what am I going to do? Like, and it's not necessarily just on us. I feel like we need to dig deeper and really ask the questions, but it's also like generally within the organization or within the agency, figuring out what are the things that we can control and we have the levers for, and what are the things that we just can't. And maybe, if you dig deeper and figure out all the different characteristics of patients that end up in ALC, which is alternate level of care, when patients are in hospital and they don't need the resources to look at that level of intensity. We've done so many different projects on it, I feel like, over the years, but it's not necessarily within the realm of authority of OH, CC, or really any one agency. It's truly a system level problem, and basically one player cannot solve it. So we've done, clustering, this, that, like, what are the, how are these patients different than the other patients? Like, what are their characteristics when they come in? But like, what are you going to do about it? I feel like then it comes down to the hospital, then they do their own analysis. Then they're like, well, we need more long-term care funding. And then the long-term care, so then it becomes just this whole thing where everybody just tries to solve this puzzle on their own, and they just can't. Like, you have to kind of do it as a system.
Well, Doug told me it wasn't his problem, whatever it is. I don't know. It's somebody else's problem, right? Exactly, right? Who is the decision maker?
Yeah.
Totally.
So for our last question, I know that we have a lot of students who would love to do this type of work and get into this field. So do you have any advice to those students on how to best prepare to try to jump into this area, both in terms of technical skills, but also soft skills?
Sure. I feel when I give advice to students, I feel like I was there like literally yesterday. Somebody was giving me advice, so I don't know why I'm giving advice to people now. It's like, I want to say, like, knowing, like, you can't know everything, but like the discipline you're in, like if you're an operations researcher, if you're a computer scientist, if you're a statistician, just know that discipline really well, like know your theories really well. And you, again, like, you don't need to know everything, but that the one thing that you're hired for, like your expertise, you need to know that really well. And you need coding skills for sure, like R and Python at this point. And I'm not talking about like big tech, like I don't know what people need at Google or whatever. Like, my lens is really like healthcare, like analytics as I know it. Like, you need to know at least R and Python. Like, there's no way without that. Like, you need to be able to really use that effectively. And then by knowing the theory, because like just knowing the coding, I feel like we hear that a lot. Like, people get really well at like coding in Python. Anybody can run a package on a bunch of data that somebody gives them, but who can, like, you should be able to really say, this time series is not appropriate for running such and such model on because the volumes are low, too high, like it's not stable, whatever. Like, you need to be able to really say that. And it's and then also kind of be able to really almost like debug or like figure out what the issues are, how to interpret the results and really explain it well. So that's like on the technical side. I feel like you should just be able to do that. And then on the soft skill, I mean, this is something that I think gets also built up during the, as you get hired. Like, I don't think anybody out of school would necessarily have that, like all of it, but communication is really important. I feel like you don't want to necessarily, or not all of the teams will have the capability to hire somebody who's like fully back end, and then also hire someone else that can, understand the technical side, but also talk to the client. I mean, I think they would want the person, the analyst, the methodologist that's hired to talk to, program partners, clinicians, like clients, and be able to understand what the problem is, and then go and try to resolve that by developing a model or a tool. So I feel like that part is something that's sometimes it is missing. Like, I know we've had trouble with that, and we always pick the candidates, like for hiring, when we are picking people, we always pick the candidates that have that bit of like communication kind of advantage. And again, like it would be hard, like out of school, obviously, as you work, you will gain more of that, but you need to kind of build the basics of that with like presenting yourself, presenting the work, being able to really speak to the work, and being able to explain the potentially like hard to understand technical methods to an audience that's a bit more kind of or less technical. Yeah.
Awesome. We have 3 questions left. I think one of them, the question from Daphne, I think we sort of covered, which says, what do you think are the key success factors to apply OR in healthcare? So she asked it before you talked about that. So I'm going to dismiss that. The second question is from Kevin asking, my question for you is this: what was your approach to project management for some of those decision support tools? For example, the surgical backlog model, where you had minimal time, 1 to 2 weeks for turnaround. Did you have defined steps or a structure to how you would meet these quicker deadlines?
Interesting. Again, like that was, I think, I mean, COVID basically has changed the way we work. Like I don't think we ever were asked to do something in a week, but now it's basically the norm. If you get a week, you're like, oh my God, I have so much time to do this. But
I know Ali Asenso did that in a visual model, but yeah.
Yeah, I think we did, like, especially for these like super like quick turnaround time, we don't go through a whole like project management thing, right? Like we just do kind of, let's just, you know, I'm gonna like try today and do like come up with whatever like prototype something, I'll show it to the team like tomorrow or the day after, and it kind of just goes through more of a like agile, but not obviously not in the traditional sense of, or like the actual sense of the agile in software development, but we try to be a bit more kind of responsive to just keep showing things and then be ready to keep changing it quickly. So we didn't do any, I want to say, any formal project management of that. Just try to be, just accept that, you know, this is it. I feel like it's a state of mind where you just realize that like there's just like no one's gonna kind of go through the regular processes of, you know, you're responsible to do this and this and that, and like the whole, you need to kind of just accept that you have a week, you have to do it, like you're just gonna kind of get to it, and then you just keep coming back. It's just a lot more communication. Like basically what happened with us was that we built one of the like a collaboration space in Microsoft Teams, which is what Ontario Health uses, but there are obviously many of those. And a lot of the communication was just by, you know, as things were developed, you know, you would share it there, somebody would message here, like you would just kind of communicate all the time instead of just being in meetings or, you know, like the way we communicated was more live, I want to say, and a bit more informal maybe.
Yeah. So lots of iterations, lots of feedback seeking, and going through that. Okay, the next question. As a student in healthcare engineering, I feel that there are not many places who are doing advanced analytics like you do for healthcare in Ontario. What's your thought on that? So who else is out there?
Yeah, it's growing. I mean, Unity Health, like St. Mike's, does amazing work like that. Obviously, like that's where our first co-op student went in the end. So like the team at St. Mike's is, I think it's great. Like I think you see it popping up at like UHN. I'm sure, I don't know the people by name, like but they have a team that does this work. I think Trillium Health is just starting to build that.
Yeah, the innovation lab. Yeah.
Yeah. So so especially at least in the GTA at the hospital level, because there's a lot of data and there's a lot of kind of operational decisions that need to be made. Like I want to say that's kind of I wish that one day I would get a chance to actually work at a hospital, because I think that the way those decisions actually impact like day-to-day operations is a lot more operational planning if you're from like OR compared to strategic planning, which is more of what we do at the agency level. So so like I would say hospital level. CIHI has oh my God, I can't remember now the acronym, but like the Clinical Institute of Health Information, or Canadian Institute of Health Information. So they have also an advanced analytics team. I know they're more of a data organization, but I think they're starting to look more into kind of just building modeling tools. I know in the pandemic they built kind of a model that looked at like hospital utilization or like hospital need for COVID patients. So they have a team. The ministry does that. Yeah, like I don't know if there's obviously enough of them when you think about like, you know, if everybody in healthcare engineering wanted to get a job like that, then is there really enough demand? But you can always also start at you know, in a different field and then switch when you find something that really matches your interest. I think if you have the technical skill set and you build up on the communication, like switching field is not a problem. We've had that in our team when we hired from non-health backgrounds. So it's
and I see some of our audience. So Daphne says Hamilton Health Sciences has an AI team, and also all the labs Tarini shares that analytics needed there too. Okay, we are running out of time, so I'm going to go through a couple of questions quickly before I leave the floor to our panelists for some final thoughts. Sorry. So, what is your model validation process?
So with everything, we usually, I mean, we're lucky with many things. We have many years of data. So we do have, a lot of time we have the luxury of just keeping aside a testing period where we just, you know, we train on a certain period of time and then we kind of check with that. For new programs, when, as I was saying, with like new screening tests or a new care model, things are a bit different. So then it's more of a, you know, does it generally make sense? Maybe some extreme testing, mostly just talking with the program or the clinical leads to just say yes or no. But when we, for programs that are existing, because we've been around for many years, like the organization, data is there for most of them to actually allow a testing period.
Awesome. And the very last question we have from the audience. You talked about surgeries that have been canceled. Was there any situation that the patient didn't show up, and was there other events? That's the question. Do you know even from the data?
Yeah, I'm not. Yeah, like you mean after they got, so when we are talking about the canceled surgeries, that's like literally like they were contacted and said your surgery is postponed, and then no new surgeries were scheduled. So so when we look at the difference, or we're trying to kind of say, you know, this is the backlog, it also includes everybody that we think, you know, a volume of patients that we think would have gotten surgery if the pandemic wasn't there. It doesn't necessarily mean that we know who those patients are. It just is kind of our best guess of, you know, we expected to see 1,000 of certain type of surgery. We only saw like 10. So, you know, those people were either never went to their doctor, never got referred, never got diagnosed, but there is a backlog there that eventually will hit the system. Hopefully if people don't have worse outcomes and, for example, die, but like you would expect to see those people with those needs eventually show up in the health system and requiring care.
Thank you. I think we're done with the questions. So Alex and Mike, any final thoughts and questions? No?
No, thank you very much. That's very interesting. You guys have been doing some really neat things.
Thank you. Yeah, I think, again, like I'm looking forward to when things kind of start to go back in the realm of normal. You know, we can, because we've been, as I said, like a bit of challenge around like hiring, etc., with everything else. So anyway, I'm hoping that we can kind of start or continue kind of expanding the team and the mandate with the new agency. So
we have wonderful students, very interested.
I know, I'm dying to like be able to actually hire more. Like I have now more vacancies than people, but eventually I will be able to.
And in the chat, Ali was putting in a plug for the MIE 561.
Yes.
Yes. The healthcare systems class for students who want to find out a little more about actually using analytics and healthcare problems. And there's a couple of, they've finally got some decent young professors teaching this course. So.
Yes, yeah, so thank you. Yeah, so we're teaching that course, MIE 561. Please take it if you're on this call. Ali and I are co-teaching that, and that actually has been a great experience as well. Like, I think I learned a lot about healthcare in Ontario when I taught that course. I never actually took that course before, so great.
Awesome. So with that, I think we'll just wrap up this session. Thank you everyone for joining, and hope to see you all in our future events. Check out our website. We'll see our future events. Bye.
Thank
Thanks.
you. Thanks. Bye.